The healthcare industry has corrupted its mission. It has stopped caring. This is unacceptable. It must change. And I'm here to invite you to join me in starting a patient revolution. I started my journey as a doctor in Peru, studying medicine at a time where my country was broken by poverty, violence from terrorism, and hyperinflation. This tested the resilience of Peruvians and all but destroyed our healthcare system. Think of Juan. He will have to wake up very early to stand in line at 4 in the morning. This will be a long line already. It will move very slowly. If he wanted to get further, he could pay his way further, but he couldn't afford it. So he has to stand, wait patiently. That was not the line to see the doctor. That was the line to get the ticket to the line to see the doctor. And so he'll get a ticket, feel lucky, go to the second line, long, and wait, and wait. Eventually, he'll find himself right outside a doctor's office, will be inside 3, 4, 5 minutes. A doctor will make a diagnosis, order a test, prescribe a treatment, and Juan was out the door. To another line, this time at the pharmacy, only to discover he could not afford the treatment that he was prescribed. Walk outside the hospital, and somebody will approach him and offer him a cheaper version, a counterfeit. He'll take it home, not get better, and find himself at 4 in the morning behind that slow line. The system, corrupt, broken, has stopped caring. 20 years ago, I came to the United States to pursue further training. In that period of time, there's been a significant change in healthcare, in the trends of health and disease. And it's been the predominance of chronic conditions. These are conditions that you don't recover from, that you live with. And it used to be that chronic conditions will accumulate in older people, and many of them will live with many of these chronic conditions. But the trend is that now those conditions are happening earlier in life, such that the average middle-aged person in this country is no longer a healthy person, but it's a person that lives with one or more chronic conditions. That means that almost everyone in this room, at a much earlier age than they would have wanted, will be in contact with the healthcare system. So, that the healthcare system works matters to all of us. To see how it feels to have many of these chronic conditions accumulate, let's meet John. So, John is a 55-year-old man. He lives with type 2 diabetes, takes 2 medicines for this condition. He also has high blood pressure, and he takes 1 pill for this condition, except that his doctor thinks that his blood pressure should be lower, given what he has negotiated with the payer for John's care. And so he adds a 2nd pill, and now every time John stands up, he gets a little dizzy. John also has high cholesterol, he has depression and a bad back, he has pain in his feet because of damage from diabetes. He also is obese. His doctor is concerned that this is not getting better, and so he would like John to meet a diabetes doctor. He would like him to meet a foot doctor and see a dietitian. For this, he will have to go to the medical center, and for that, he will have to take some time off work. And when he gets there, he'll be told, you got to cut the carbs, cut the fats, cut the salt. You need to exercise. I know you have a bad back, but you can do it. He'll be told to check his feet. John hasn't seen his feet in decades. He has a big belly. He'll be told that he needed to take his pills, but we know he's taking his pills because he's getting dizzy when he stands up. He'll be told to check his sugars and write them down and bring him to the office. But his doctor will look away from it into the computer to those laboratory measures like the A1C measure or cholesterol measure that the doctor is being held accountable to. And John's weight will be the thing that the doctors will discuss, not the fact that John lives with pain and can't sleep. Now, the reason John can't sleep is that he used to be in a company where there were 3 accountants, then 2, and then 1. He needs to perform. The deadline is always now, and he's noticing that the numbers of this company are not adding up, that this company is going under. And with that, potentially his job and his ability to deal with his financial obligations, including his mortgage. But the thing about home that worries him the most is not the mortgage, it's the fact that his oldest daughter has come back to live with him, with 2 beautiful granddaughters. And she's coming away from an abusive relationship, and she is addicted to painkillers. And as John is opening the mail, he gets a letter from his primary care doctor that explains that because he's not meeting the parameters of care set for quality, he needs to get another primary care doctor. Now, that's not very caring. This system cannot care about John or for John. In Peru, I understood it: poverty, violence, hyperinflation. Here, what's going on? Well, first let's find out how is it that doctors know what to prescribe patients. Mostly is, if they're good, by reviewing the medical literature, the science. Now, if you are careful, you'll notice that the majority of new drugs, the majority of new treatments and tests are evaluated by those who market, by those who sell those same tests. It shouldn't be a shocking statistic, but when industry evaluates its own products, they're twice as likely to results favor the product compared to an independent assessment. And if the test is true, is positive, this result is 4 times more likely to get published and to be published quickly. So by the time the independent, more moderate assessments become available, most of the doctors have developed already a level of enthusiasm for those treatments, for those tests. And so they will prescribe them enthusiastically. The treatments that they will prescribe have become increasingly more expensive. It was revealed recently that the price of the top drugs in this country has doubled in the last 5 years. Remind me of hyperinflation in Peru. And the problem with this is that it used to be that we were told that the price of the drugs reflected the cost of developing these drugs, the cost of innovation and manufacturing, distribution, and marketing. Now we're told the price of those drugs reflects what the market can bear. In other words, what is it that people can pay? The end result of caring fundamentally about the profit of the investors and stockholders is about 1 in 4 people now struggle to afford some of these drugs. Some of them are life-saving. And we're pricing people out of what could save their lives. Healthcare companies, what we used to call hospitals and clinics, have gotten into the game. Their executives, many of them, are held accountable to short-term targets and goals, which by necessity will have to be operational and financial. Money will then displace the patient as what matters most. In the consultation, it means that if you have a certain amount of time, doctors will have to pay close attention to documentation and to get adequate billing for that visit. And that may crowd out the agenda of the patient. The patient will no longer be first. This soul-crushing reality is affecting our frontline healers. 1 in every 2 doctors in the United States are now reporting symptoms of burnout. Among them, the inability to feel empathy for whoever is suffering. For some reason, patients have been spared the result of this lack of empathy, but not those doctors' families, with doctors exhibiting higher rates of divorce and suicide. When people live with multiple chronic conditions like John, and doctors are held accountable to metrics that don't reflect the situation of each patient. A patient with multiple chronic conditions will have multiple doctors, multiple treatments, and they will accumulate. The result is in this picture. Look at Maria Luisa. Look at her desk. Plenty of health care. But now look at her eyes. Look at her face. Is this the face of health, of thriving, of adapting and growing? No, she's overwhelmed. We overwhelm patients with multiple chronic conditions because we just don't know what is the work of being a patient. There is not a single medical textbook that describes the work of being a patient, what it is, how much it is, how it accumulates, how to alleviate it. We don't measure the work of being a patient in our practice. We just don't know it. Furthermore, we assume it's not a big deal. How do I know? Because many people think that the patients and the caregivers are the least utilized resource in healthcare. In other words, we should transfer more work to them. They're free. And yet, we're overwhelming patients, we're overwhelming caregivers. Now, at this point, I think it's completely reasonable for you to go, wait a minute, Victor. We've all heard of moments of incredible medical prowess, scientific miracles that lift people from the dead, that give people a second chance. Medicine, we have the best medicine in the world here. And I know that. I know that because of my parents. They have benefited from that. I know that because my kids benefit from that. And then you might say, but Victor, I have wonderful encounters with my clinicians, with my doctors, with my nurses. There are incredible moments of human connection that I can tell you stories. And that is the thing. These exceptional situations should not be evidence that the system is all right. They are evidence of hope. We can get that even though the system is broken. This is as unacceptable as it is modifiable. We have a healthcare industry that has corrupted its mission and has stopped caring. And what we need, what we want, is careful and kind care. Careful that is for us, for our situation, in our circumstance, for who we are and for what we want to do. And you need to understand it, and the doctors and nurses and healthcare systems need to understand it. And that happens when we have a conversation. And it's careful because it doesn't harm to the extent that it's possible. It was revealed recently that healthcare is the third cause of death after heart attacks and cancer. And kind, which comes from the root kin, seeing the other as if the other was a member of our tribe, of our family, just like us. And so treating them with respect, particularly respecting those resources, energy, attention, time, that are so precious when you're sick. How might we get there? For the last 10 years or so, with a great group of colleagues, we've been doing research to try to answer this question. How do we get care that is best for this patient, that is best for their family? And we've looked at the conversations between patients and clinicians. And we brought in tools that set the record straight so that the clinicians will not have to use the biased evidence, the biased science that was available to them. Correct the record, and then create those conversations. But magic happened. Not only was evidence translated in a way that was meaningful to people, but people will become engaged. And other important things that support the patient who's suffering and support the healer who's struggling is that there was joy emerging into practice. We took our magic, because we were excited about it, and went around the country, public libraries and living rooms, and started engaging patients, saying, how can you then bring similar tools, like those that support the clinician and patient interaction? How can you bring similar tools into the conversation so you can have high-quality conversations? And we heard incredible stories, like a man who delayed open-heart surgery because of fear. Because in his imagination, his doctor will open his chest and will hold his heart in his hand. And this patient was really concerned that the doctor will drop the heart and the heart will go around the operating room. And he thought it would be silly to ask, and so he did it, and so he delayed surgery. Or the woman who asked for genetic testing, the doctor said, you don't need that, but never inquired why she was asking. She never met her father. She was curious about her future. Or the woman at age 40 opens the mail, happy birthday, you're 40, you need a mammogram. And she did her homework. And she thought, I'll get it later. I'll get it at some other time when I get older. And told her doctor. And her doctor said, well, wait a minute. My performance measures include proportion of women at 40 that get their first mammogram. Please do it for me. And she got a mammogram to make his numbers better. We needed to improve that. And one of the ways we found to improve it is to prepare people to ask for those conversations, to make sure that those conversations bring their situation in high definition so that the treatments and tests recommended will be the right ones for them. And so in your package, there's cards that are available. And these cards allow you to prepare for those moments, understanding why it matters what you're asking and what you're nervous about. Preparing ahead of the consultation with these cards could potentially bridge that gap and open those consultations, make sure that they're about you. Improving the conversations one at a time is not going to change the system that we have. But it is the start of a grassroots movement. It is the start of individual advocacy. where we stand up as patients and we make sure that we get careful and kind care. And then we get collective action. And in that collective action, we find ourselves changing this unacceptable system. We can't wait for policymakers to do it. The system is too powerful as well as its lobby. Doctors, nurses, their livelihood depends on this system as it is. But they will join because they're struggling too. So, while we're healthy, while we have our voice, while we have our energy, let's work together. Let's start a patient revolution.